Oh, okay, very good. So, our closing panel. So, I've invited a panel of experts to speak about some of the essential aspects of multidisciplinary care that we as surgeons need to increase our awareness of and advocacy for to improve outcomes. This includes advocacy for professional education for our non-physician team members and advocacy with manufacturers to enhance clinical care provided by our non-surgeon team members, in particular our audiologists. Another important area is enhancing pre-surgical imaging, an area where there is a lot of variation in clinical practice. So our panelists today are René Gifford, who is the Chief of Audiology and Research at Hearts for Hearing, Kevin Brown, who's an expert cochlear implant surgeon and translational researcher at UNC, and Jace Wolfe, who's Senior Vice President of Innovation at the Oberkader Foundation. And I'd also like to acknowledge Camille Dunn's contribution. Camille was invited to be a panelist, and she is the director at the University of Iowa of their Cochlear Implant Clinical Research Center. And she's also a clinical director at the Institute for Cochlear Implant Training. And she unfortunately couldn't come, but she did share information with René, and René is going to present some of her material, which I'm really looking forward to hearing. So René, I'm going to ask you to start.
Thank you, Nancy, and thank you for this invitation. This has been a phenomenal meeting thus far. There we go. Okay, so I'm going to be talking, here are my disclosures. I'm going to be talking just briefly about the audiologist's role in cochlear implant programming and some things that we can utilize to help improve outcomes for our patients. So, of course, we know that the number of factors that influence outcomes is enormous. In fact, this is really just a sampling of probably what's dozens of potential factors that we know of today, and there might be even more, of course, that arise in the future. Now, one of the biggest things, however, that we don't talk about is that we are very responsible for how our patients are doing. Because if we're not programming that device, it doesn't matter how well you place it as a surgeon, they're not going to be able to take advantage of that information. So I always talk about this as being the elephant in the room because not every audiologist is created equally, just like not every surgeon might be created equally. So we do need to assure that we're educating our audiologist on every aspect of cochlear implants if they're going to be working in this particular field. So, of course, with respect to cochlear implants, there are so many parameters that we have to have a well knowledge of. And in fact, all of these parameters interact with one another. So if you adjust one, you have to know what that impact is on others that can impact their electrical dynamic range and the way in which speech in the large dynamic range is repackaged into a very small dynamic range. So there's a lot of things, and this, unfortunately, is not really discussed in our graduate education. So I think many of you know that I was in academia for almost 20 years. I was at Vanderbilt University at their audiology AUD graduate program. And so I want to talk just briefly about the educational program for audiologists. So ASHA's CAA, or their accreditation for audiology, they do require almost 1,900 observed and supervised hours for audiologists to graduate with their degree. But there are no specifications with respect to how many of those need to be with cochlear implant patients. So all they have is they have a number of cochlear implant competencies that that program and that curriculum needs to cover, and they're listed here. How that program decides to cover those competencies is up to that program. So many audiology programs will have a single course on cochlear implants, which doesn't really go into that much detail for what we need today and what we need for the expanding population that we're going to be covering in the next few years. And the manufacturers provide, of course, excellent training as well. But again, if they don't have that foundation early on and understand the aspects of just electrical circuits and signal processing and everything that goes into this, they're not going to be the expert cochlear implant programmer that we need. And of course, there's continuing education like this today. which is great. I do want to briefly talk, and this is the section that Camille was going to talk about, but I am also the co-CEO of the ICIT Clinical Board of Directors, along with Dan Zeitler. And we're going to talk a little bit about what the course offerings are. So there are a number of course offerings that are for professionals. We have advanced surgeons courses, cochlear implant courses. For audiologists, we have team efficiency courses, and you can see all of the individuals who direct these courses. In addition to that, we have international versions of these courses so that we open this up so that individuals can, from around the world, can take part in this, and then we will interact with them in live, real time for a number of those sessions. So for these are the number of clinicians that have been trained over the years at the Thomas Balcony Institute for Cochlear Implant Training. So thus far, you can see that almost 1,400 clinicians have been educated since 2015. And of those, 808 are audiologists, which I'm really proud that that's a number that has really exponentially grown in the last few years. Now, as part of the AAC, we do provide a clinical confidence score. So we provide a survey before the course starts and again after that 10-week course. And we ask them to rate their clinical confidence in all of these measures, as you can see here. I want to also focus on that very last question. How confident are you in your abilities as a CI audiologist? Keeping in mind that these are practicing audiologists seeing cochlear implant patients. Okay, so what we're looking at here is we're going to look at the response as a function of the different categories. So the course content knowledge, their practical skills, patient and professional interaction, advanced audiology techniques, as well as their overall audiologist confidence. So before the course, here were the scores, keeping in mind that 5 is very confident. So we have individuals who are seeing patients who do not say that they are very confident working with cochlear implant patients. So that in and of itself is a bit concerning. But this is what I take a great pride in, because there is a lot of growth among that 10-week program for our audiology enrollees. And so we are getting into the in between somewhat confident and very confident by the end of that session. Okay, now with that, I'm going to transition very briefly to talking about some of the things that we can use as audiologists in conjunction with our surgical colleagues to identify patients who might have extracochlear electrodes. And I want to acknowledge my two collaborators on this particular topic, Andy DeFries at Vanderbilt and Jordan Holder, who is at Hearts for Hearing with me. All right, extracochlear electrodes. Of course, we know this is not a huge problem amongst our implants base, but we know anywhere from like 9 to almost 14% of patients who've been implanted with cochlear implants have at least one extracochlear electrode. Of course, we know if there's an extracochlear electrode that is not deactivated, that particular frequency region is completely missing from that child's input. So there's poor auditory outcomes associated with this. We can get non-auditory stimulation as well as poor speech production, which is something that I care about particularly. I'm not a speech language pathologist. I do wish that I had done that and got dually certified, but it's so important. We always talk about receptive, but how one expresses themselves and how others can understand them is critically important for a child's socialization. So extracochlear electrodes, a study has shown that about 6% are detected by surgeons. Now, I do have a huge caveat here because this is based on what's in the operative report. And I know that many of you, myself included, I have templates and dot phrases, and sometimes you just kind of get carried away and you put something and you might not necessarily include a particular piece of information. So I do take that with a grain of salt. 60% have been identified by audiologists on the basis of like neural response telemetry or ECAPS or NRI or ART, and as well as loudness balancing. So if we happen to do psychophysics and we're stimulating some of those basal electrodes and they're not showing any loudness growth whatsoever, that can also be a key indicator. Of course, 100% of these extracochlear electrodes are identified by CT. So we do know that, of course, CT is not always available for every single child, at least not intraoperatively. And then once they are implanted, if they're very young, getting them to sit still for a CT is really not possible until they get maybe about 5 or 6 years of age, at least in my experience. So there are some additional options that we have right now that can help us identify what there might be extracochlear electrodes. So first of all, I want to talk about like impedances. So contact impedances as shown on the left. This is what we've typically historically thought about when we talk about electrode impedances. So this is just measuring like the electrical resistance for a single electrode. So basically it's telling us information about that local electrode to neural interface and is that electrically functional. It doesn't tell us anything about how things are interacting with the different electrodes in the array. In combination here, we have the non-stimulating electrode voltage potentials. There's a lot of names for this. You might have heard TIM, EFI, or IFT for the three manufacturers. They're all the same thing, which is non-stimulating electrode voltage potentials. With this, we are stimulating a single electrode and then measuring the voltage responses across all the other electrodes. So what it's essentially giving us, it's giving us sort of like the geometry of the electrical current spread in the cochlea. And so it's telling us information that we can simply not get from standard electrical impedances. So as shown here, we have a particularly completely inserted electrode array on the left. And then what we're seeing is the chart that we would get from, say, a TIM or EFI or IFT in the middle. And then we have the heat map. Now, shown here, you can see that there is considerable electrical voltage potentials that is measured across the entire array. So that's telling us that that current is really spreading through that perilymph and through that cochlea, and it's going through the entire array. In contrast, however, this particular electrode array has several electrodes that are not in the cochlea. And you can see that, let's see, right here, these particular potentials are much lower than the rest. And the heat map is particularly evident because you can see the current spreading here, the current flow. And then as we get towards the base, there's really not much. And so this is the sort of like the telltale sign that these are extracochlear. So we can actually get this information intraoperatively, which is really helpful because we don't necessarily then have to get a CT at that particular moment. We can be rest assured that this is completely within the cochlea. So I'm going to give you a very quick case study. So this is a 4-year-old male. He was sequentially bilaterally implanted with Advanced Bionics HR90K at 12 and 13 months of age. His parents were doing everything. He was in speech language therapy at least once a week, and he also was additionally seeing an auditory verbal therapist once a week. His receptive and expressive language was actually a roughly age normative, and his social communication was starting to really struggle because he was not understandable. So his intelligibility was very, very poor, despite a lot of speech language intervention. Here is an example of him speaking at baseline from the PLS. Oops. I don't know if I'm going to be able to. Oh, here we go. Here's the mouse. Could you please turn them up? I'll try that again. AV, can we get some audio? Okay.
Red, blue, orange, yes.
So notice on yes, he's very, he's not getting those high frequency electrodes because here is his image. So you can see that these two electrodes are out of the cochlea. And that is in the frequency region of about 3,800 up to 8,700 hertz. So a lot of fricatives there. So if we look at the speech banana, of course, we've got K, T, F, T, TH, and S that he's not getting. So he is expressing what he's hearing. And so what we did was we were able to enroll him. We were able to see that these were extracochlear. We deactivated those electrodes, reallocated those frequencies, and you can see that within a period of 6 weeks, his LNT word scores, they improved dramatically. But what I'm more proud of is his speech understanding. And so I will finish that, or I'm sorry, his articulation. So this is him after 6 weeks.
Blue, yellow, red, orange, green, purple.
It's hard to tell there. But if I show
Red,
you,
blue, orange,
sorry, we're having,
yes.
I'm going to move on.
Yellow.
Ooh, okay, sorry about that. So I do want to show this spectrogram. And so at baseline, you can see he does have some of these formants, but he is not really producing anything above about K, and there's very limited information there. But after he got those 2 electrodes deactivated, look at the representation of those foramens. It's much more accurate. And then he has presence of very high frequency speech information. So that was an example of just a really easy case of giving them back that information, which we would have been able to identify with the TIM or EFI or IFT. He just recently finished his first semester as a 6th grader. I got an email from his mom now, so a lot of time has passed, and he is absolutely thriving, great reader, completely age appropriate. So this was an example of a great case study. And with that, I'll turn it over. Oh, okay. Yes.
So you talked about, CT identification, but you also talked about TIMS and the other methodologies. Are those, or is TIMS and its sister and brother,
Mhm.
you said that all the manufacturers have this non-radiographic way
Mhm.
of telling where electrodes are, but do our audiologists have easy access to that in the standard software that they're given by the manufacturers?
Great question. So 2 of the 3 manufacturers have access to it relatively easy. So it's Cochlear and Medel. Advanced Mannix has it with the AIM tablet. So if you have an AIM tablet in your clinic, you can get that information. I think the hardest part, however, is that very few audiologists are in the OR and to get that information prior to closing.
Why would you want to get that in? So here's another thing. What about electrodes that come out over time?
Yes.
Because I mean, you there's other approaches to than getting a CT. I mean, if we see that it's in as a surgeon, for instance, you could get just a baseline X-ray.
Mhm.
I mean, it's not as good as a CT, but if you have a baseline and then you have one later and you see that the angular insertion depth has changed, you have an idea something has moved. So I guess what I'm wondering is, could these TIMS and the other technologies be used as a way to routinely screen for whether there's been a shift in the electrode arrays over time?
Absolutely. Yes. And so the problem, however, is that with the kids we have today, or all of the patients, we don't have those historical measures because we've really only had access to them in the last few years. But going forward, absolutely. So if we get something like either intraoperative or very closely post-op, like even at activation, we can get sort of that baseline, voltage potential across the array. And then over time, should there be an extrusion, we would be able to see that on that particular matrix.
Would it be helpful if, when the audiologist sat down to program, the first thing they pressed was a button that did an analysis of what electrodes were extracochlear and needed to be turned off?
Absolutely. Yes. So either having this matrix of electrical voltage potentials at activation and or some combination of imaging, whether it be plain film CT or plain film X-ray or CT scan, would be amazing. So like when I was at Vanderbilt, we had intra-op due to Rob Labity's input there. And so at every activation, I knew exactly how many electrodes might be out of the cochlea. And so now we have that tool in addition to this, like you said, non-radiographic, no radiation exposure needed, because we have access to that in the clinical software.
I mean, because the radiation exposure and the cost are really
Huge.
major factors, especially when you think of it, it's an ongoing issue.
Absolutely. And also, if you have a young enough child, you're not necessarily going to be able to get that without sedation. So you can't get that, those imaging until later, which is, of course, then another problem. We don't want to have to sedate these children. And then if the cost associated with that and the potential side effects.
Thank you. Next, Kevin, would you go? Thank you.
So for the purposes of this session, Dr. Young asked me to talk about the importance of MRI and preoperative planning for pediatric cochlear implantation. And I hope after this discussion, everyone comes away with the idea that certainly it's okay to get CT scan as well, but really all pediatric patients should be getting MRI scans. So the goals of preoperative imaging are the following. We want to identify that the cochlea is present. We want to determine its morphology and internal characteristics, i.e. the fluid characteristics within the cochlea, or whether there's bone present within it. We want to identify the cochlear nerve is present. We want to identify issues that could potentially complicate our cochlear implant surgery, such as an aberrant facial nerve, otitis media. We want to assess the risk to the contralateral ear if the hearing is still functional on that side, because parents are going to be interested in whether this is going to potentially affect their child's other ear. We also want to improve counseling by identifying potential issues that may slow their progress with a cochlear implant and or influence their habilitation with their cochlear implant. We also want to be able to identify incidental pathology that may necessitate modification of the cochlear implant to permit treatment or monitoring. As far as our protocol, we typically obtain an MRI brain and IAC without contrast. So this is a cranial nerve 8 protocol as an initial screen for pediatric patients with bilateral or asymmetric sensorineural hearing loss, as well as for kids with SSD. And this is an important point. Sometimes you get pressure either from your radiologist or sometimes pressure from insurance carriers that they want the study to be done with contrast, and it is actually distinctly recommended against by the American Association of Pediatrics, where they indicate that because of potential cellular toxicity and unknown effects, they recommend the use of gadolinium contrast only be used sparingly in infants and young children. It's also important to include the entire brain to permit full evaluation for other intracranial concerns, as we'll touch on momentarily. Personally, if the MRI is abnormal beyond incomplete partition 2 or an EVA, I'll typically also get a temporal bone CT. But if that MRI scan only shows pathology up to that level and nothing more significant than that, I don't routinely get CT scans prior to cochlear implantation. I don't find that it adds really significant additional value. People may disagree, but that is how we practice. As far as an overall comparison of CT versus MRI, this is what I'm going to go through in the following slides. Morphology, you obviously get that with the CT, but you get the additional information of what the fluid characteristic is within the cochlea on an MRI scan. Cochlear nerve, you'll see a bony cochlear nerve canal on a CT scan, but you'll actually see the nerve on an MRI scan and know that it's actually there. We'll talk about why that's important. As far as issues complicating surgery, CT is oftentimes going to be a better study for that, again, because it's going to show if you have a facial nerve that's in an aberrant position that you need to prepare for. MRI scan does not typically show the facial nerve to that well of an extent. As far as issues complicating rehabilitation, CT is really not necessarily going to suggest that to you. MRI scan is going to potentially show some of those parenchymal or developmental issues in the brain that may suggest that you're dealing with a more complicated issue than just a child that has hearing loss. As far as risks to the contralateral ear, certainly if you see EVA or other type of malformation on the contralateral ear, that can help you know what the future is going to be of that contralateral ear. But with an MRI scan, you're going to get better information, potentially identifying some of the stigmata of CMV or other problems. And then for incidental pathology, CT is really not going to show you incidental intracranial pathology to any great extent. MRI is excellent for that. So as far as cochlear morphology and characteristics, both MRI and CT provide information on the size and the shape of the cochlea. Both of them allow discernment between major malformations. This is the same patient here as here. This was an IP3 patient that I implanted, and you can see that you can easily recognize there is an IP3 malformation both on the CT as well as the MRI. So they both allow discernment between major malformations. You can also see on a MRI scan, it's actually quite easy to visualize an EVA. You'll typically see the larger interlymphatic sac back here as well that will frequently be dilated and quite obvious on your scan. Only MRI or CT will demonstrate changes in the cochlea that are occurring late with inflammation such as labyrinthitis ossificans, but only your MRI scan will permit evaluation of loss or changes in the fluid signal within the cochlea that precede ossification. And I just highlight this image here that shows that you had a CT scan demonstrating an open cochlea, and when you look at the MRI scan, you discover that there's going to be significant fibrosis that's really going to impact your ability to place an implant. CT and MRI can both demonstrate evidence of cochlear nerve deficiency. This is a child that I implanted with bilateral cochlear nerve deficiency, and you can see there was a very narrow opening. This was better than the contralateral ear, which is why we chose that particular one. And we can see on MRI scan that there is absence of a cochlear nerve in the typical position here. The important thing to realize is that the cochlear aperture in the IC can be normal, but the cochlear nerve can be either absent or hypoplastic. Nancy did a study back in 2012, looked at 10 confirmed cochlear nerve deficiency ears and found that 2 of them had normal cochlear nerve aperture on their CT scan. And Dr. Berman did a study in 2016 showing a very similar result, that 10 out of the 64 ears that had cochlear nerve deficiency had a normal internal auditory canal. So it is important in those cases of children that you don't just assume that because that cochlear nerve aperture is present that there's a normal cochlear nerve traversing it. You have to have an MRI scan. Issues complicating surgery, both MRI and CT will demonstrate evidence of chronic otitis media. CT is superior for tracing the pathway of the facial nerve distal to the internal auditory canal. CT is recommended in cases in which the MRI suggests major inner ear abnormalities, or if there are other concerns that you have, so brachial cleft anomalies in which the facial nerve may not be following a typical pathway. CT is optional but not required in cases of normal or near normal inner ear morphology on the basis of MRI. Issues complicating rehabilitation. This was a study that came out in 2020. I'm not going to go through all of it, but basically these were pediatric subjects with sensory neural hearing loss, age matched to normal controls. And what I want to highlight is that there is a significantly higher likelihood that they're going to have brain developmental abnormalities. And I think that's really important to understand, because when you're starting to question why there may be outcomes that are not reaching what you would typically expect the average outcome in a child getting a cochlear implant, it may be that you need to realize that there may be developmental abnormalities that are affecting what their ultimate ceiling is. As far as risk to contralateral ear, ears with sensory hearing loss do not necessarily progress at the same rate in children. There's an increased risk of progressive loss in the contralateral ear. If there is an increased risk of progressive loss in the contralateral ear, this is something that's obviously going to influence parental decision-making. Both CT and MRI can identify the malformations that portend progressive hearing loss, but MRI alone is really going to demonstrate the changes that are highly associated with congenital CMV that's going to enable you to counsel that parent. You really need to get the cochlear implant for that first ear, because that second ear may be going right behind it. And this is going to permit you to do that. As far as incidental pathology, MRI has much greater sensitivity in revealing intracranial abnormalities. A negative CT has no negative predictive value for abnormalities of brain parenchyma, and the brain findings that you see may influence the timing of implantation. If there's a more acute problem that needs to be contended with, it may influence which ear you choose to implant. If you're having to follow something over time, you want to have that magnetic shadow potentially away from it. It may decide whether you actually include the magnet with the cochlear implant, or whether you take that out to permit better visualization of that area as well. So with that, I'll conclude, hopefully convincing everybody you better get an MRI scan on every child you put a cochlear implant in.
Thank you, Kevin. Yeah, I'm not going to question you. Forget. Jace.
Hello, my name is Jace Wolfe. I'm the Senior Vice President of Science and Innovation at the Oberkotter Foundation. Nancy Young has asked me to come today to talk about 2 different things. She has asked me to talk about some of the resources that Hearing First, which is an initiative of the Oberkotter Foundation, provides for both caregivers and families of children with hearing loss, and also the professionals who serve them. She's also asked me to come today and talk about the role of the pediatric audiologist and the listening and spoken language specialist in collaborative care on a cochlear implant team today. And I think I've found myself, as I've been here at this excellent meeting with so many great presentations, framing that role maybe in a whole different light. As I hear wonderful presentations about advances in cochlear implant technology, drug-eluting electrodes that will release anti-inflammatory agents into the cochlea, hearing preservation techniques, neurotrophins that might regrow cochlear nerve fibers and allow cochlear implant recipients to have better outcomes than they've ever had before. Gene therapies. The sky seems to be the limit today. There's never been a better time to serve children with hearing loss and to maximize their potential to be able to listen and read and talk. But I would propose that there's also probably never been a more important time to ensure that you have good pediatric audiology services and listening and spoken language services on your cochlear implant team. There have been reports over the past couple of years of large numbers of children who didn't get an accurate diagnosis in their first year or two of life. And if that's the case, even with gene therapies, we might miss the window of time where we can maximize the benefit of those technologies. Dr. Gifford mentioned the role of the pediatric audiologist in programming cochlear implants. There have also been reports of children who are underamplified with their cochlear implants. It's not caught for several years, and it has irreparable harm on their language development. And we simply can't have those things happen. We have to position our pediatric audiologists so that those kind of mistakes do not happen. Another critical component or ingredient in the success of children who are deaf or hard of hearing is access to a listening and spoken language specialist. If you haven't worked with a LISL specialist, what they do, they're typically speech language pathologists. They have specialized training to work with parents, to coach parents, to support them to create a language-rich listening environment for their child. If you heard Dr. Patrick Wong's presentation yesterday, he talked about the importance of meaningful parent-child interactions or conversational turn-taking. He mentioned that those type of interactions are really the fertilizer that mediate brain growth in the spoken language areas, that allow the brain to develop, to allow the child to achieve optimal listening, spoken language, and reading abilities later in life. And there's an abundance of research that supports that. Patricia Kuhl, Janet Worker, these data come from Rachel Romeo's lab, showing that the more parent-child interactions that we have, the more activity you can see in Broca's region during communication, and the better the spoken language outcomes. And what's really exciting about that Dr. Wong showed yesterday is that we can coach parents to increase parent-child interactions. And when we do that, and those interactions are increased, we see a thickening in the cortex, in Broca's and Wernicke's region, and we see improvement in language development as well. And most of these studies are just short sessions of parent coaching, which would pale in comparison to what a family would receive from a LISL specialist, which is oftentimes weekly or biweekly sessions. And the reason this is important is that we have to meet parents' needs. And we know from research that about 95% of children who are born deaf or hard of hearing are born to parents who have normal hearing. And we know also from research that over 90% of these parents desire for their child to learn to listen and talk and read. And the great thing is that if we can implant early, if we can provide good otologic care, good pediatric audiology, and good LISL services, then we have good news to share with parents that we can expect exceptional outcomes. And I'm going to share just a few studies with you that show the outcomes of children who were served at centers where they have those things in place: good pediatric audiology, otology, and LISL services. So these scores, these data come from New York University and their cochlear implant program. Most of these children were implanted early. They're neurotypical, severe to profound hearing loss with cochlear implants. You can see by the time they reach an age where they can participate in open set speech recognition testing, typically 80 to 90% of these children score above 80 to 90% correct on these tests. So exceptional outcomes. This should be the expectation for the kids that we serve. Maybe more exciting than that, Lisa Davidson and colleagues at Washington University looked at reading development, adolescents with cochlear implants. These are all children who participated in childhood development after cochlear implantation study. We know historically children who are deaf and hard of hearing, when they graduate high school, they read at a fourth grade level, median level. These children, in contrast, who received implants early and had good access to good therapy, 80% had age-appropriate reading abilities. What are the two most important things to reading skill development? It's oral language abilities and phonological decoding, or the ability to be able to hear the letter-sound relationship and understand phonics, which again is so critical in the role of the LISL specialist to support those abilities. Another study in the UK, the auditory verbal program with 129 children, showed that 97% of neurotypical children achieved age-appropriate spoken language. These are all the children that participated in this program by the time they reached school age. And 52% of children with additional disabilities did as well. And we don't want to underserve children with additional disabilities or to set our expectations too low, because if you've worked with children with multiple disabilities, you know that they can have great outcomes if they get really intensive services. We also know that their hearing and their communication abilities can be one of their greatest strengths or assets as well. But they need that good care as well. And then other studies that show that when families commit to listening and spoken language, their reading and spoken language skills in middle school and high school are once again age appropriate. So I don't want to belabor the point. Dr. Gifford showed that children or that students, AUD and LISL students or professionals oftentimes do not get that kind of training in school when they leave the AUD program. So they're at the mercy of continuing ed that they can get once they become professionals. And that was the motivation for the development of Hearing First by the Oberkotter Foundation. Hearing First seeks to provide information, knowledge, learning experiences, resources, and the opportunity for connection through community for parents and caregivers of children with hearing loss and the professionals who serve them. We have over 80 courses for pediatric audiologists and listening and spoken language specialists. They're provided at no charge, and they can get continuing ed credits through ASHA and through the American Academy of Audiology upon completion of those courses. We have learning communities where parents and professionals can engage with one another. We have great resources that help parents get started off on the right foot once their child has been identified as deaf and hard of hearing. We have YouTube channels where more information is available, and a private family Facebook group as well. So I urge you to share these resources with your professionals that you work with at home and with your families as well. You can access the website and these resources through the QR code here. Thank you for your attention.
Just to highlight I mean, it's very hard to find professionals who are appropriately trained in listening and spoken language. I looked at ASHA's website. I mean, it was a number of years ago, but you could the amount of time required to address that topic could be fulfilled with one lecture and zero in-person clinical experience. So these people don't grow on trees, and this is very hard to get the training. So that it's any of this training is great. So and really changes the outcome. So I'm going to do try to get through as many of my little cases as I can. So the first is a 9-year-old. They're a consistent user of bilateral implants, and they stopped using the left device due to poor sound quality. The kid reported it was too noisy and too loud. And when the audiologist looked at the electrode impedances, the apical half were low. So, Renee, what would you do next? What are you thinking? What would you do next?
So if they're really low, I would want to know approximately how low they are. Are we talking about short circuits? Are we talking about potentially a device that's failing? I would want to look at ECAPs across that array. I would want to get the EFI, TIM, or IFT, and ideally some imaging. Not that imaging in the apical half would be necessarily out of the cochlea, but of course I always find that information useful.
So an X-ray was done and confirmed that that it looked like a full insertion. There hadn't been any movement from comparing it to the plain film in the OR. And as Renee is saying, this is not particularly suspicious for backing out because we're talking about low impedances. What else? Let's say this is not a recent case. Let's say you didn't have access to EFI or the audiologist didn't know how to do that. There's another resource, right, outside of our center, and that would be to ask for the manufacturer, right, to come in and do an evaluation. The manufacturers come in and do evaluations if you suspect there may be a failing device, as Renee raised. Well, that was done. And because a failure was suspected by the audiologist, and this was the sentence in the report, and this is the topic of discussion. Based on the results of the evaluation that the manufacturer did, they recommended disabling half of the electrodes. Do you think that's what do you think about walking around with half of the available electrodes? Do you think that's good clinical care?
I especially don't like it if it's all in a row. Like if you have every other, I'm more apt to potentially try it, but the entire apical half, no way.
But let's say, not this particular case, but let's say it's not all in a row and it's half. Why wouldn't you, like, what would make you sort of like, what would be your thinking? Why would you not say this is a failure and I want a new device?
I wouldn't. I would say it's a failure and I want a new device. And I'm pretty adamant about that with the manufacturers.
Yeah, but I think one of the lessons here, I think, is that, a lot of times there isn't always perfect communication between the surgeon and the audiologist often relies on manufacturers. And like if the surgeon, I think most surgeons, if they heard half of them weren't working, would say they need a new one. But I'm not sure that always happens when you have audiologists who, as was pointed out by Camille's Dunn data, they're not that confident in their skills. The manufacturers sometimes are the ones, in essence, providing training on their own device, and they're told to just turn off the electrodes. The other thing that's a concern is even if turning off the electrodes improved their performance, I mean, isn't it a bit like perhaps an SSD or something like that? What about listening fatigue? What if you're doing okay, but you're working harder?
Yeah, that is not okay because we already know that children with hearing loss have much higher listening fatigue and just issues with that than the typical child. And of course, we know from like the American Academy of Sleep Medicine, like having a sleep deprivation is one of the most a huge risk factor for poor academic performance. And so if you look at that and think about children with hearing loss who already always have that sort of listening fatigue, we don't want to make their life harder. We want to make things easier.
I'm going to move on to the next one because I have so little time. I may run a little over, and Nick may have to drag me off the stage. But anyway, this is a child who was implanted as an infant bilaterally, and they come in for a routine visit, and they had previously had great thresholds and great speech perception, and now in one ear the thresholds are lower across the board, and the speech perception test is abysmal, and so. What are we going to do next, Renee? What information do you like to ask from the audiologist? And I don't have EFI.
Yes. Oh, okay. So have any impedance problems, anything changed? I want to look at ECAPs to see if there's changes there because that can be suspect that it's maybe not the device, it's something with the child. That's highly unlikely. In this particular case, I'm going to want to know, are there extruded electrodes? What's going on? So I would prefer get a CT.
So here's some additional information. So one of the things that I found fascinating is that this child was a consistent device user. There were 0 tolerance issues. There was 0 facial nerve stim. The impedance were rising on the 5 most basal electrodes, and there was no ECAP on the 8 most basal electrodes. So what does that say to you?
I think they're extruded.
So that is indeed what's going on. And it's hard to see the electrode, but this is the tip, and then it goes like this. So we see a nice, we see it, the turns in the cochlea, a nice angular insertion depth. And this is the tip of the right ear, and then it just goes straight out. So I don't think that all audiologists and surgeons realize that people can tolerate this. That not everyone is symptomatic. I found that this is an old case. I found this quite fascinating, and not all the electrodes are high either. Um, and Anyway, so let's move on. Here's another case. This is a little different drummer. This is a kid who preoperatively, before their MRI, before their CI, a pre-surgical CT and MRI without contrast was ordered. You see contrast here. Why? The MRI was being monitored, and the person monitoring it realized there's a lesion on this MRI, and they added contrast. It wasn't that it was ordered. Um, and So here you see turns out this was an optic nerve tumor, and this is the CT, and the tumor that's very obvious here is not, you can't appreciate it there. So Kevin, I mean, not just for this case specifically, but for cases where there's a lesion found on the MRI, what are some of the considerations? What are some of the things that, like, say, you could do it for this case or another case you've come across? What are the next steps? What's going on in your mind?
Yeah, I think in general, the prognosis of that particular intracranial lesion, is this something that's going to have to get treated immediately? Is this something that you potentially, even though we'd like to implant children in a timely fashion, that if this is life-threatening, this needs to be addressed first? If it's something that is going to be observed, is the location of your cochlear implant ultimately going to interfere with the capacity to monitor that? If that's the case, how can you mitigate that? Can you mitigate that by potentially implanting on, an opposite side if there's a sidedness to the lesion? Is it a circumstance where you need to remove the magnet to avoid interference with future studies? I think those are probably the main things that jump to mind.
Yeah. What about have you run into situations where a little different scenario? The child has a programmable VP shunt. Programmable VP shunts are programmed with a magnet. They have a magnet in them. Okay, and so that changes. You change the magnet to change the shunt flow. And do you want to comment about that?
Yeah, actually, we did a series talking about management of this at our institution, and I know Mayo did a larger series and incorporated some of our data into it as well. But there's really a couple of options. Number one is that with respect to the shunt, you can change it to a non-programmable shunt and have a discussion with the neurosurgeon about the feasibility of doing that. The other alternative is that if the shunt obviously is on one side, you can do your cochlear implant contralateral to that. Now, there's still some risk if the magnet is brought into proximity on the wrong side. That can potentially alter the function of the shunt. But in general, if they're going to have a cochlear implant that's contralateral to that, that seems to be safe.
I think there's no question on the contralateral side, the magnet internally is safe. It's far enough away, although not on the ipsilateral side. But children take off the externals, and God knows what they do with it. So there still is the risk of changing the shunt flow. So another approach is that they have to use tape to keep it on, which is not it's less than ideal, although we have had patients who've done that for a while until the neurosurgeon felt comfortable getting rid of the programmable shunt. But these are all just things to think about. And, with all of these implants that are happening in the future in the brain, I mean, who knows what other situations we're going to have to really, we'll have to be creative, like Charles Lim talked about. Okay, this is, I know I'm out of time, but I think this is a really important issue, and this is something that was raised by René H on our women's, we have a women's Google group for neurotology. Okay, and so we all know about the diametric magnet, and it's really marvelous that all the implant manufacturers have these modern magnets, and it's made imaging better afterwards and safer. Well, who knew? Prone MRI is a thing, and it's particularly important for breast cancer or for women with dense breasts that are being monitored, um, that are at risk for breast cancer. And Renee Benakis raised the issue that she has patients who the her institution and neighboring institutions won't allow the patient to undergo a prone MRI. And this is really, I'd like to open this to the audience if you've had any experiences that are similar, because there were other women on the Google group who expressed concern about this, and it's fascinating. There's no good deed will go unpunished sort of situation. So this is specific to Cochlear Americas, but only to their latest and greatest, diametric magnet. Okay, and the risk is not, it's not a big deal. I mean, the risk is that the magnet might become demagnetized and the patient might have some discomfort. Well, we know we can handle that, right? But the problem is their language is very specific. They define that it has to be supine on the patient on the back. So nowadays, more and more, the powers that be in our institutions are doing risk management and looking at the details and are just saying, oh no, there's a risk there. You can't do that. And that's what Renee ran into. And it required major negotiations at her medical center and a lot of outlying smaller centers. It's just a no. Um, and I just think it's, and the other companies with even though with the same type of magnet, there's no problem just because they didn't put as much detailed language when they submitted it to the FDA. So I don't think it's a serious issue. It's not a criticism of Cochlear Americas, but the issue is it's an access problem for patients potentially. Renee, quick thing for you. Here's an audiogram. Or Kevin, same thing. Here's an audiogram. Great thresholds. This parent every year went to get a hearing test at a different place because they said my kid doesn't hear well, and they were always told the thresholds are normal, there's not a problem. And then they happened to come to our center, and I think I can see why there's a problem. On what bells does this ring, Kevin and Renee?
I can't quite read the speech discrimination. There's a marked asymmetry between the two, and that doesn't happen when you have thresholds at that level unless internally there's a pretty significant problem. Typically, you see cochlear nerve deficiency in those circumstances.
Yeah, that's right on the money. So this patient had nerve deficiency on that side. And I think many of us think, well, if our patient has, some residual hearing, not this dramatic, but some residual hearing, they would still be a candidate. That they wouldn't have to worry about nerve deficiency. Like if the CT looked normal and there's residual hearing, why should I worry about it? Well, this is sort of a dramatic case of thresholds are fine. I guess you need fewer nerve fibers for a threshold versus discrimination. And yet there was still significant nerve deficiency. This is my closer. Renee, this is for you. Okay, reimplanted. They were great before their device failed. They got reimplanted. And before the reimplantation, the complaint was like whining and all these problems, and they got reimplanted. And at 3 weeks post implant, the kid's a rock star. 4 weeks post implantation, he says, there's buzzing in my reimplanted ear, and he wasn't using it. And he comes to the center, and the audiologist does all this reprogramming, and he leaves happy. And then they come back a week later, and he says he can't hear from either ear. And the thresholds are excellent, the impedances are normal, there's no external equipment problems. And they made mapping changes to try to address this. But when he left, he wanted his original maps.
This is tough. If he were a little older, I'd be thinking maybe this is some hormone issue, or if he's on like human growth hormone potentially. That's what I would ask questions about that, because otherwise I can't imagine you would see extrusion that quickly. And he did so well, and then you saw a change. So that's what I would hypothesize.
That's a very clever answer about, because sometimes there are hormonal issues, and I agree we have issues, although bilateral I've never seen, but anything's possible. But this is the answer. My mom let me stay home from school when I can't hear well. I get to come to appointments and miss more school.
Clever guy.